Welcome to this webinar. It's my absolute pleasure to welcome all of you to this webinar entitled Transforming the Culture of Care Improves Preterm Survival. My name is Frank Kaharuza, and I'll be moderating this webinar this evening. So here's our brief agenda today. We are going to have a few introductions and frame the context of today. Then we'll review the intrapartum packages of interventions that were used in this program. We shall present to you the exciting study primary results. And then we'll have a question and answer session. And after that, we shall get closing remarks from one of the team here. So today we'll be hearing from the three core principal investigators who did this work. On the extreme right of the extreme right or left of my screen, Peter Waiswa is the Associate Professor of Health Policy and Planning and Management at the School of Public Health, Makerere University College of Health Sciences. He served as the Principal Investigator for Preterm Birth Initiative in Uganda and is also our host for the dissemination today. The next person out there is Fregona Otieno. She's the Principal Research Scientist and a pediatrician based at the Center for Clinical Research, Kemri, Kenya. She served as the Principal Investigator for the Preterm Birth Initiative in Kenya. And then last but not least is Dr. Dilys Walker, who is a Professor of Obstetrics and Gynecology and Reproductive Sciences at the School of Medicine, UCSF. She served as the Principal Investigator for the Preterm Birth Initiative East Africa. We are also honored and welcome people who are critical to this work. Dr. Harriet Nambuya is a consultant pediatrician working at the Jinjan Regional Referral Hospital, which is one of the sites of the study. She served as the co-PI and mentor and is very well versed in the intervention packages and offers a unique perspective in terms of how it was being implemented. And last but not least is Dr. Jesca Nsungwa Sabiiti, who will be offering us the closing reflections. She is the Commissioner for Maternal and Child Health at the Ministry of Health in Uganda. She's a child health expert with a doctorate in health systems development and a master's in pediatrics. She has more than 15 years of experience in developing, implementing, managing, and research programs in Uganda. She has championed several newborn and child health programs, including IMCI and community case management, and has been at the forefront in designing innovations and extending newborn health services to primary care levels. And again, my names are Frank Kaharuza. I'm a public health specialist, currently working with USAID Uganda. I have over 29 years of experience as an obstetrician gynecologist, and as well as an 18-year stint as a reproductive health epidemiologist. I currently I've worked before with Makerere University with the US Centers for Disease Control in Uganda, and I'm currently working with USAID Uganda. Now, before we dive in, I wanted to help frame this important work. The study is an excellent example of an implementation research trial conducted in real-life settings in both government and faith-based healthcare facilities, both in Uganda and in Kenya. There are a couple of points that I need to highlight. The intervention was a complex, adaptive, and iterative, and based on the local contextual issues that were found in the two countries. The implementers of the intervention were actually the health cares found in the facilities and were supported by the project staff. They represented the frontline providers, such as doctors, nurses, midwives, as well as the facility leadership and administration. The study relied primarily on the routine health services data collected by the health system, which creates a path towards improvement in data quality, local capacity strengthening, and sustainability. This implementation actually continued, especially in the face of very high staff turnovers and industrial strikes that occurred in Uganda and also in Kenya. With this context, my hope is that you can all appreciate how this team executed a robust scientific trial, which has been published in the Lancet Global Health. And for some of you who know Lancet Global Health, it's a real world setting with sustainability in mind. As you listen to their presentations, please feel free to type in the Q&A box or the Q&A Zoom function as the questions might arise. We will have time at the end of the discussion to respond to them, and we might also be able to respond to them real time. To get us started, I now turn over to Dr. Flegona Otieno, who is going to take us through the first part of the presentation.
Okay, thank you very much. I'm privileged to be part of this team. And I know that all of us, we are all boxed into the COVID issue, but it's also important to note that November is the month when we celebrate the World Prematurity Day. So we are actually very delighted to share with you our results of this very important study in such a month that we do celebrate the World Prematurity Day. This study, as already alluded to, explored the impact of an intrapartum and immediate newborn care package on fresh stillbirth and preterm and low birth weight neonatal mortality rates in Uganda and Kenya. So I believe that as we reflect on the World Prematurity Day and all the issues matters to do with prematurity, we are all very much interested in knowing what can end or what can actually mitigate this vice. Next slide. We all know that preterm birth is the leading cause of neonatal mortality, followed by intrapartum related events. And all these two put together account for over 50% of all neonatal deaths globally. Next slide. The Every Newborn Action Plan strategic objectives was rolled out in 2014, and it's one of the robust global efforts to reduce neonatal mortality and fresh stillbirth rates. A major part of this strategy focuses on facility-based existing interventions during labor and immediately after birth. So therefore, targeting this particular window is very, very important and has been reported to be having greater impact on saving the most of lives. Next slide. So what did we do? We conducted an unblinded pair-matched cluster randomized controlled trial. In Uganda, we worked in Busoga region with Makerere University leading and working together with the Uganda Ministry of Health. In Kenya, we worked in Migori County with the Ministry of Health and KEMRI team leading the research work. Interventions were delivered at the facility level and focused on quality of care around the time of birth and immediate postpartum period. The study was implemented in 16 health facilities in Migori and 4 in Busoga region. As you can see, comparing the two regions, they are very similar in terms of health indicators, especially child survival indicators, but also the geographical region is more or less similar. Next slide. As I mentioned, we had our intervention package It was a package, and it was composed of 4 particular items. And the first was data strengthening, followed by the modified Safe Childbirth Checklist, quality improvement collaboratives, and the last was PRONTO simulation and team training. Next slide. 10 of the facilities, which we call the control facilities, received part of the package, which was data strengthening activities and modified Safe Childbirth Checklist only. Next. While the intervention facilities, the other 10, received the full package, which now on top of data strengthening and modified Safe Childbirth Checklist, had also the quality improvement collaboratives and PRONTO model simulation and team training adapted for preterm birth. Next slide. What was our hypothesis? So our hypothesis was that the full intervention package would reduce the combined incidence of fresh stillbirth and neonatal mortality among preterm infants by 30% compared to the incidence in the control group. And as you can see on this slide, our conceptual model of theory of change was based on on improved quality of care. Next slide. Our primary outcome was combined fresh stillbirth and neonatal mortality among eligible infants. So I just wanted to take a minute to explain what our eligibility was. We defined eligibility as live registered fresh stillbirth with a birth weight between 1,000 to 2,500 grams, or if their recorded gestational age was below 37 weeks, then the birth weight would be below up to 3,000 grams. This was done to be able to get the most vulnerable babies by weight or gestational age without using a lot of resources to follow up healthy, heavy, late preterms or misdiagnosed early term births. We conducted an intention to treat logistic regression, adjusting for clustering and also for pairing with the standard error estimates. Next slide. As already mentioned, these interventions were rolled in a real-world context. And as you can see on this slide, the first 2 components of the interventions were rolled earlier, that is data strengthening, as well as the Safe Childbirth Checklist, and later on, we had PRONTO and quality improvement added. In that real-world setting, it saw Uganda ending the study a lot earlier, December 2018, but in Kenya, where we had a long nurses strike taking about 8 months, the study was extended up to May 2019. So basically, these components were just rolled out in a real-world context where we had all these things varying delivery volume, staff turnover rates, industrial strikes, and the like. Yeah, so next, my next slide just shows the picture showing the kind of real world. Of course, this is extreme, but these are real pictures. As you can see, environment of the records can be that disorganized. The maternity wards can be that crowded. The newborn unit can be that crowded. And even the delivery room can be that open where privacy is very little. Next slide. I think I would therefore then just take this opportunity to give the platform over to Harriet so that she can give us more descriptives on our interventions and the study methods. Welcome. Thank you.
So thank you very much, Fligona. So I'm going to take us through the components of the implementation process. The first was data strengthening. Data strengthening was done across all sites, and it was the first core component that we intervened with. And the first thing that we did was to ensure that we do not create parallel systems. So we had to use the existing data sources, that is the maternity register. And before we did that, we had to review and streamline the indicator definitions and standardize them. And we did this by inviting health workers in a workshop and take them through the key indicators of interest. And that was gestational age, the birth weight of the baby, and then also the APGAR score plus the discharge status. Like you can see in the picture, to standardize it across sites, we had to provide pregnancy wheels to ensure we improve on gestational age so that it is standard across sites. You can see some health workers being shown how to use a pregnancy wheel. Then the data team used to make monthly visits to these sites, the intervention sites, and their role was to collect data from the registers. But as they did that, they would review the data completeness and correctness, and they would give feedback. And then the data would be aggregated and fed into the dashboard, which was site specific, and it would be shared to the different sites every month. And lastly, we did biannual data quality assessments where we could disseminate this information or the data to the key facility stakeholders. Next. So in data strengthening, which personnel did we focus on? We focused on health records officers, the staffs working in maternity and newborn care units, and in addition, the people who are leading the facilities, that is the facility administration. And how frequent would we do data strengthening? We'll do it every month in each facility, lasting about 1 to 2 hours doing that interaction. And then also we had, during our study duration, we had 2 data quality assessments. Next. So a modified Safe Child Checklist was our second core component intervention. And briefly, a Safe Child Checklist is a WHO tool that was created based on evidence to improve maternal and newborn outcomes. So before we did that, we had to study and see if this modified Safe Child Checklist could be tailored in our setting. So we had to engage the key stakeholders and align this checklist with the existing national guidelines, both in Kenya and in Uganda. And we adopted, like I've mentioned, the WHO Safe Child Checklist to focus on how to identify preterm labor and how to manage a baby, a preterm birth. But in addition, we also realized we needed to create another point in this modified Safe Child Checklist called triage. Triage was very critical in helping health workers identify those mothers who are in preterm labor and are candidates for antenatal corticosteroids or maybe possible referral. And this modified Safe Child Checklist was distributed across all sites, intervention sites, and it was incorporated into the existing patient charts. Next. So the people who were the targets for us to be taken through the modified Safe Child Checklist, these were people, midwives working in maternity ward and newborn care providers. And how often would we check on them regarding utilization of this checklist? At least once in a month in each facility, and would take about 1 to 2 hours. But in addition, to ensure that the uptake of this modified Safe Child Checklist was good, we had to do additional reinforcement during quality improvement sessions and also PRONTO activities. This is particularly in the intervention sites, like you will see later. Next. So this slide shows us the third component of our intervention, which is PRONTO simulation and team training. PRONTO is the non-profit organization which is based on evidence, and it helps in creating training curriculum, which is low-tech but highly realistic. And it emphasizes good communication skills and team building. Like you can see in the pictorial over there, we have a team of health workers where we have a patient actress with a health worker attending to this patient actress, But he has mobilized that team because he's attending to this mother to this patient actress. So it is a real, highly realistic simulation, and we emphasize communication and team training. But it's also very critical because it helps health workers to identify actionable system change ideas, things which they can do, identify and be able to improve as they offer care. And in the curriculum also emphasizes kind and respectful maternal care to these mothers, which is very, very critical. PRONTO is not a new intervention. It has been implemented elsewhere in 13 countries. So Uganda and Kenya were just some of the countries coming on the list where PRONTO has been implemented. Next. So what in PRONTO simulation, what were the activities? The activities in PRONTO included the standard basic emergency obstetric newborn care. That was the content. But our emphasis in that content was related to intrapartum and immediate postnatal care practices. So we focused on ensuring that every midwife is able to do a gestational age assessment, be able to identify preterm labor, and it was synergized, like I mentioned, with the use of a modified Safe Child Checklist. And in addition, another activity that we did in PRONTO simulation was to train what we call PRONTO mentors. What did the PRONTO mentors do? They provided bedside mentoring and knowledge reviews to the healthcare providers during the intervention. Next. So this slide is showing us, like I mentioned, PRONTO creates a simulation curriculum. So this slide is showing us what curriculum was contained or was implemented in the different sites in both Kenya and Uganda. So there were 12 SIMPACs. Those are the 12 topic areas where we focused on. And these topic areas were mostly focusing on how to identify a mother in preterm labor, how to conduct, to care for a mother with a preterm birth. But in addition, we also took care of other topic areas, like you can see postpartum hemorrhage, because it's very critical, it causes maternal death, and then also preeclampsia is very critical. Maybe just to highlight one or two from this slide of the topic areas, like one highlighted in blue, we had a simulation where there was spontaneous vaginal term delivery of a floppy infant with severe postpartum hemorrhage. Here we could see the health worker demonstrate the skill and mobilizing the team through the good communication skills. On one team caring for this baby who needed resuscitation, another team is caring for this mother who is having severe postpartum hemorrhage. So in the end, we're able to save both the mother and the baby. And then another key area that I just wanted to highlight is caring for preterm labor and birth of a non-vigorous neonate who may require CPAP. Here we wanted a health worker to demonstrate the skill of identifying a neonate, a preterm baby who will need continuous positive airway pressure. So he has to identify this infant and be able to transfer to special care unit. So all this is done using good communication skills. Next slide. Next. So who were the personnel targeted as we implemented PRONTO? There was still the maternity ward and newborn care providers, but then also the quality improvement mentors. So our curriculum in PRONTO was designed for 58 hours. So in total, we had 7 PRONTO trainings, plus additional bedside mentoring visits in Uganda. So in the mentoring visits, the mentor will visit the site, interact with the health workers, and is able to identify their needs, and is able to be mentored. If there is need to have a simulation, then they will go ahead and organize one and have a simulation. Because each site had a package fully designed to conduct a simulation training for PRONTO for each site. Implementation site. Next. So when we implemented PRONTO, what did we see? So we collected process data This process data was to see whether there was a difference that was being made as we implemented PRONTO. One of them was change in knowledge regarding caring for a mother in preterm labor and birth. So these were some of the key topic areas where the simulations were done. Now you can see there is a marked improvement in knowledge uptake among the health workers. So the light, you can see that there is improvement before in most of the key areas, like use of antenatal corticosteroids, markedly improved, maternal sepsis, just to mention a few. So there was transfer of knowledge that was remarked as we implemented PRONTO. Next. So our last and final intervention component was quality improvement collaboratives. Quality improvement was only being implemented in the intervention sites. So what did we do? Before we started quality improvement, we had to create quality improvement teams, and the team would constitute about 3 to 12 people who would discuss quality improvement projects. And in their discussion, they would focus, their basis was using a PDSA cycle, that is plan, do, study, and act, with the support from quality improvement coach. As they implemented the quality improvement projects, there are certain particular indicators that we're tracking to see whether there was a change, whether there was an improvement. So the key indicators we're tracking were gestational age, documentation in the maternity register, utilization of antenatal corticosteroids to mothers in preterm labor, monitoring labor using a pathograph, and uptake of kangaroo mother care, which is a key intervention in caring for preterms. But just to mention, in addition to that, we would also have what we call quality improvement learning session, which were country specific, where teams from different intervention sites would come together and share, discuss their quality improvement indicators and change ideas. Like you can see in the pictorial over the screen. One of the team members is sharing what they had done in their facilities. During these quality improvement learning sessions, there was a lot of peer learning, because you would find some facilities are doing well in one indicator, the other facility is not doing well in another indicator. So there will be a lot of peer learning. What change idea did you do? Can we learn? Can we copy? Can we carry it back to our facility? Next slide, please. Next. So the people who are engaged in quality improvement were mostly maternity and newborn care providers, but also in addition, the leadership in the facility was very, very key, because in quality improvements, there are certain things which are changes where you need an administrator to take lead or to take an action. So that's why we involved also the leadership. And how frequent would we have these quality improvement discussions? It would have quality improvement facility meetings every 2 weeks. And these meetings will be facilitated by a QI mentor who would visit the site. And then later we also had 5 quality improvement collaborative learning sessions in each country. Like I've described what happens in a collaborative learning session. Next. So this is some of the indicators. When we started implementing quality improvement, we wanted to document the process. Is it making a difference or a change? So like I mentioned, our 4 key indicators, we have put them in this graph. As you can see, initially where we started in 2016, you can see most of the indicators were way below, I think 50 and below. But by the time we completed the study or the intervention, some of the indicators had reached 100%, like KMC uptake was at 100%, and most of the other indicators were way above 80%, which was very good. Next slide. So this slide is showing us some of the indicators. In quality improvement, there are certain things, like I said, they would discuss their quality improvement projects, but they would also have change ideas, which they would test using the PDSA cycle. So some of the change ideas were very successful, and we have shared some of them here. Like when we look at kangaroo care uptake, just to highlight one of the change ideas which caused a marked improvement was the counseling mothers before, during, and after delivery, as you can see. So we found out that if a mother is counseled prior to delivery of this preterm and even during and after delivery, the uptake of kangaroo mother care was much higher and very good. As you can see, it caused a sharp rise in improvement. Then another indicator that we wanted to share was antenatal corticosteroids. One of the things that I wanted to share was a change idea which caused the difference was the policy change allowing midwives to prescribe dexamethasone. A midwife identifies, yes, this mother is in preterm labor, he needs antenatal corticosteroids, so he will go ahead and prescribe and just report or document and give the information to the clinician or the doctor. Next. So thank you very much. That brings me to the end of our implementation process. I'll transition to Peter to share with us the results. Thank you.
Thank you so much, Harriet, for such a very good presentation of the intervention component. I'm now going to be presenting the results. Next slide. So during our study, we determined 28-day outcomes among eligible newborns. I'm going to be taking you through our consort diagram. Consort is basically the trial outline. We began with 23 facilities in both Kenya and Uganda, including referral hospitals. We excluded 3 referral hospitals because we could not peer-mark them, and they included only births occurring at 20 selected facilities. So for the case of Uganda, for instance, this study was done in the Makerere region. We excluded Jinja and the Iganga in the location, but actually they received the intervention, but they are not part of this analysis. I'm sure in future we're going to be doing more analysis to see if we include them, what did we get? So in the end, we ended up with 20 facilities, which we are peer-marked on volume, on neonatal outcomes, on facility readiness, and also in terms of country. We excluded all term babies, full-term babies, all macerated stillbirth, and all those birth weight, all of those birth babies whose birth weight was below 1,000 grams in the primary analysis. This being a real life situation, because we didn't have special teams, the people who are doing consenting were the user nurses. So in the end, we consented 66% of eligible infants in the intervention sites and 60% in the control sites. So we missed quite some because like a baby is born in the night and on the weekend, and they leave before they being consented, which is the usual practice. So in the end, we ended up with about 1,500 babies in each group. Our loss to follow-up was 12.2% in the control sites and 8.4% in the intervention sites, which is on average about 13%. Next slide. Our full intervention package reduced the odds of combined fresh stillbirth and neonatal mortality among eligible infants by a full 34% compared to the intervention group. So you can see quite a significant result of a simple QI package reducing preterm mortality by 34%. And I hope you remember that actually our primary outcome was not just in facility birth, as I'll be showing you in the next slide. This data was adjusted for pairing and for clustering, and we did further adjustment for C-section rates in those different hospitals, for infant sex, for multiplicity, country, because we're in 2 countries, also for birth weight volume in terms of the different facilities, and also the facility readiness. But even with this adjustment, the estimate was not substantially changed. Next slide. And here, I think for me, is the most interesting slice for the results. In red here is our combined outcome. So when we were designing the study, initially we wanted to look at post-discharge mortality. But then in the discussion with our team of advisors, we said we want impact on neonatal mortality, those preterms who die within the neonatal period. So in the end, we end up with our main outcome being a combined or a composite outcome of fresh stillbirth and the 28-day mortality. Remember, these babies, this intervention was only in a facility, but we looked at outcome beyond the facility. And the impact here was a reduction of 34% compared to control size. But also, as you can see, the confidence intervals, we also reduced perinatal mortality, which is interesting, and also reduced 28-day mortality when you just look at preterms. And also we reduced pre-discharge mortality, and also the intervention reduced fresh stillbirth. So this is a package that impacts across the continuum. And if we had the power for maternal death, we suspect maybe would have also had an impact on maternal death. Next slide. Now, the confidence intervals were quite wide, and which was, as you saw in the previous slide. And we wanted to go in and understand further what was happening. And but because we had 10 facilities, just 10 facilities in each arm, which were of different sizes and readiness and stuff like that. So we did a sensitivity analysis, excluding 3 pairs individually or together, and also did a sensitivity analysis with all facilities to see this variation, what is it about? But even after doing this sensitivity analysis, the overall results were not affected, meaning that these results remain quite robust. Next slide. Now, these trends for which we see were consistent across the 2 countries. Here in blue, you can see one is Uganda, mostly the bigger bars, and the shorter bars is Kenya. The intervention had a greater impact in Uganda than Kenya. And, but there was major differences between Kenya and Uganda facilities. Uganda facilities were all hospitals, whereas in Kenya, some of the facilities were health centers. And the Uganda facilities were larger. They had about 2.7 times more deliveries compared to Kenya facilities. All of the Uganda facilities had C-section capacity. So you could argue that our results for Uganda are actually generalizable to hospitals, mostly district hospitals, because this analysis doesn't include the referral hospital. But the Uganda facilities had slightly lower facility readiness scores at baseline, which is a problem with our facilities that in terms of readiness for newborn care, our facilities need more capacity building. So that was the difference, and we see that in Uganda, the intervention was much more effective than in Kenya. Next slide. This slide is just confirming that in Uganda, actually the intervention was, even when you just do a per country analysis, in Uganda, the intervention reached significance, although it did not reach in Kenya, although the results that we present overall is combined, but if we were to do just a Uganda-specific analysis, the intervention was still effective, meaning that these results have huge implications for what we can learn in scaling up preterm care in Uganda, and also definitely in Kenya. Next slide. And this slide shows that all births benefited from exposure to the package. As I presented before, the intervention impacted first stillbirth, it impacted pre-discharge mortality. All these fresh stillbirths, etc., among those babies that we suspect were preterm. Next slide. Now, before I present some of the limitations of our package, one of the, for me, the exciting things about the work is that although we had an intervention in facilities, it impacted outcomes even at 28 days when most babies have gone home. Meaning that a lot of these things that Harriet explained, the counseling, the KMC that we have started in the facilities benefited these babies even beyond the facilities. Most likely mothers continue practicing KMC and some of these things beyond facilities. So I think what we do in facilities is so important for saving babies. The counseling, the KMC, and all those other things are quite important and are continued beyond facilities. But our study had some limitations. Just like any other study, some of which are shown here. For example, gestation age. In our setting, gestation age is difficult to measure, and it can be unreliable in our settings because first trimester ultrasound is generally not available. But as I said, for the composite outcome that we used a combination of birth weight and the recorded gestation age that we captured using the wheel and other measures. Second, because of our practical approach, we use existing health facility staff and also existing health facility data to collect data, but also to consent. So we try to be more practical, but we ended up missing about a third of eligible babies. We tried to look at these babies we missed. Did they affect the result? And when we looked further, we realized that no, this does not affect the results because there are no difference between these babies that we failed to follow up or to include in terms of neonatal mortality, pre-discharge, in terms of maternal mortality, in terms of maternal age, in terms of C-section rates, in terms of multiple gestation or infant sex or gestation age, suggesting that bias in the inclusion was unlikely to occur, although we are likely to have excluded it completely. But the results still remain robust and should be able to inform what we do in Uganda, in Kenya, and other related countries. I'll now invite my colleague, Professor Dilly Walkers from UCSF, who was the overall PI for the study, to make the rest of the presentation. Dilys.
Great, thanks so much, Peter. And let me just begin by telling everyone what an honor and pleasure it has been working with my colleagues in East Africa over these years. It has been a really rewarding experience. And as Peter said, I'm going to tell you a little bit about our reflections on why this might have worked and worked so well. As he stated, our package led to reductions in fresh stillbirth and pre-discharge mortality among these small and preterm babies, but it also led to reductions of fresh stillbirth in all births, so not just restricted to preterm infants. And this, as we were reflecting about this, means that providers were one way or another making a different decision at the moment about whether or not to resuscitate a baby, how to resuscitate a baby, and how to follow that baby. So the real question is, so why did they make that different decision? And what is it about this full package of interventions that led these providers to make different decisions and to act at critical moments? Next slide, please. So we believe that it really had something to do with the power of this integrated package. And as Harriet and others have explained, this package was designed intentionally such that the activities could be synergized and reinforce one another. You heard that in the PRONTO simulations, the QI officers were part of the simulations. They saw and change ideas were generated there that were then taken over to the QI. The Safe Childbirth Checklist was integrated into the simulations so that providers could recognize the value of such a tool more effectively. And through this, all the providers had strengthened clinical skills and data use because that was always being fed back to them. Next slide, please. However, we think there are a number of critical factors around all this that help this implementation of this very complex intervention package. The first was visibility. Defining an issue sparks change. We made prematurity an issue, and we placed value on those preterm lives. And that can make the first critical stage in the evolution of achieving real meaningful gains. And then the next thing was teamwork, establishing regional peer networks for providers and facilities, created more confident and accountable, and they were supported by these communities. And that sense of teamwork was consistent across all levels of this intervention and project. And then finally, engagement. We really relied on the engagement and the support of our Ministry of Health stakeholders and partners in both countries. We relied on local leadership throughout the study and through dissemination, and we continue with that engagement today. Next slide, please. So, putting it all together, we believe that by naming the condition, we increased the visibility of a problem that was always there but suddenly became visible, and it led to better counting of that problem. By teaching the providers how to care for these vulnerable infants, we increased knowledge, which translated into increased confidence and use of evidence-based practices, things like kangaroo mother care and antenatal corticosteroids. Remember, we did not introduce any high-tech equipment or supplies throughout this entire period. So we know that these happened, but why did they act to save these small and fragile babies? We think it's this continuous cycle that helped providers build confidence, shift their attitudes about how likely that their actions would lead to success, which led them to take action, have success. That success was counted, and it was further supported. And we believe that this is part of the answer to that question of how this managed to create such change. Let me now pass it back to Peter, who will close this up. Thank you.
So just to summarize that, as we said, the intervention was able to reduce the odds of dying by 34%. But in real terms, when you look at the combined first stillbirth and neonatal mortality, which was our main outcome, the intervention was able to reduce mortality from an average of 23.3% to 15.3%. Definitely, this is important, although more needs to be done. I mean, we need to be saving more babies, but it says that in terms of a package at the beginning, we can make progress and then later add more advanced interventions. And this work was published in August in the Lancet Global Health. It was actually followed by a commentary by colleagues from Oxford and Kemri in Kenya. And next slide. We, of course, want to be grateful for people who supported us. First, being here in Uganda, I'll actually start with the ministry. Dr. Jesca was at the center of this, giving us a lot of advice, but also a lot of mentors. I can see some of them, like Dr. Rebecca Nantanda, Of course, we also want to thank our funder, the Bill and Melinda Gates Foundation, and I know Manfree from the Gates Foundation is on the call, listening in, but also the PTBI East Africa Strategic Advisory Board. Actually, overall, our advisors were led by Dr. Cotino, whom we all know, and we would like to thank the Ministries of Health of Kenya and Uganda, and the facility administrator, the leaders, the providers, the staff, and of course, the mothers and the babies, and all the data collectors, the research teams from Makerere University, from Cambridge, from UCSF, and the PRONTO International. I just wanted to leave one final thing for me, which is from the depths of my heart, that one of the things for me I'm most proud of is, although in Uganda we worked in 6 hospitals, the work on prematurity has actually continued beyond the study period. And although it may not be as perfect in some places like Kamuli and Iganga, there's been so much further improvement. The work after the 6 hospitals also expanded to 7 health center force. And one exciting thing was recently they transferred a nurse from Chiganda Health Center in Mayuge. She went to Health Center 3 and she sent us pictures recently that she had started a neonatal unit in her facility without anybody telling her. So the passionate people that we've left behind, and in the region, we have a WhatsApp group which has providers for more facilities, very busy discussing issues of mothers and newborns and prematurity. Thank you so much. I would like to pass over to the moderator. Thank you.
Thank you very much to you all who have presented such exciting things. Now I'm going to ask all the panelists to switch on their cameras, and we could see them because we are now getting into the Q&A period where we want to kind of discuss some of these issues that have been brought up. And I see we are running a little bit out of time, but we'll have, I've looked at the question and answer sessions, and I think the biggest question that is being asked here is a question on sustainability of these achievements after project closure. And I've heard Peter's passionate appeal and a description of what has happened afterwards. So I'm going to leave Peter a little bit because he's, I think he's more biased. Let's hear from Phlegona and Harriet on what they see as, how can they sustain the gains of their achievement? What do they think is out there? And then we can have this discussion. So let me start with Phlegona.
Thank you very much. Yeah. The same kind of excitement. In fact, the first with like there's no
maybe switch off your video. We can't hear you well, so switch off your video and we might get better coverage from you. Thank you. So go ahead.
Okay, you can give me a minute just to put on my hotspot if you don't mind.
Okay, sure. Okay, Harriet, in just a minute, tell us sustainability, especially with provider attitude, fatigue, and available resources.
Thank you very much. Maybe what I can say, I'll speak on the perspective because I'm also a health worker. The most exciting thing is to see what excites the health workers to carry on, not to get tired of what was happening, is the joy of seeing a baby who was born very small and live to survive and thrive to their full potential. And I know even as we work today, these babies come back in the follow-up clinics, and it's very exciting. A baby whom you saw 1 year ago or 2 years ago in the project walks in and now he's growing, normally as expected in their milestones. As a pediatrician, to me it's very exciting, even to a midwife. They are really very, very motivated that even a baby as small as maybe 28 weeks or 26 weeks, you're an obstetrician, you know that, they declare them as abortions, but we have seen them live to their full potential. That alone motivates the health workers to carry on the mantle of caring for this preterm baby. So the knowledge has not died away. The fire is still burning because of what they see and what they have attested to. That's what I could say. Thank you very much.
Okay. Thank you. So Fregona now.
Okay, let me try. I hope it's better. So I was saying that even in Kenya, we have a lot of excitement over this project. In fact, there are good memories of Preterm Birth Initiative work in Migori where we did the work. And we have very excellent quotes from the healthcare providers from that end. And we always have them following us up and reporting to us what they are doing. They may not be able to do exactly the full package as it is, but they have some definite good remnants going on, particularly on the Safe Childbirth Checklist and also in PRONTO. And even on data strengthening, we have great impacts because we had a lot of changes made, and we have a lot of good reception from the sites. So my response to how sustainability may work is just very low investment can be made with with very high gains, particularly if our ministries of health can be able to push a little bit. But we have converts that are already sold out for this, and I don't think there's a lot that needs to be invested to make it happen. Thank you.
Thank you very much. Invest in attitude, motivation, and this will kind of work. Now, I know we are running a bit out of time, but I would like to ask Jesca to give us a few of her closing reflections on what does she see and how can we move this thing forward. Jesca, over to you. For the other questions that are in the chat, we shall definitely ask the team to answer them, and we'll get to all the questions either answered in the chat room or as soon as Jesca is done, if we have more time, we'll be able to do that. Jesca, over to you.
Thank you very much, Frank, and well, good evening and good morning to everyone. It's actually great for me to be part of this webinar where we are talking about premature birth. This month in November we've been commemorating the perinatal month in Uganda. And I'm glad that we're able to join you, our researchers and the team, to share these good findings. I want to thank also those who have managed to join this webinar, especially our partners, in-country partners, the Ministry of Health, and a special thanks goes to the district people who have also been able to link in. I want also to recognize our colleagues from UCSF who partnered with us in this investigation. I have been asked to do some reflection on this presentation, this dissemination. And I must say it's certainly wonderful to see the results of this study. And I thank the team, I continue to thank the team. Not only have they been able to conclude this pioneering research, but they've also been able to establish a foundation for PTB research in this country. Not only in terms of exchanging knowledge, but also the immense capacity they have built among our participants who were in this research. We are all aware of the significance of this study. We know that preterm birth has remained stagnant or persistently stable in Uganda and maybe Kenya for decades. We know the significance of the impact, the long-term impacts of preterm birth on the infants themselves and the families who must cope and care for these babies. And this work is also coming amidst growing evidence in areas such as KMC, preterm birth, which means that we have the potential to actually implement these interventions. because the evidence and the technology is improving, including some work also on developmental-based care for the babies. But despite all this, the impact of our work in the country on preterm birth, again, has remained very dismal. Like it has been reiterated that in other places that our health systems can be judged by how we care for newborn babies, and especially preterm babies who can die easily or can be saved by an effective health system. And preterm babies, therefore, are a test of how we respond to our most vulnerable citizens. And we think it's very important in Uganda, for example, as we're moving to a new emphasis on human capital development. I think these small citizens will need to be a central focus of our work. And I want to thank you very much. This study explored the ability to integrate and scale a well-founded, a well-known package of services in an environment where strengthening of the health system factors was taking place, which resulted in significant increase in survival of even the small and least mature infants, as well as fresh stillbirths also reduced, showing that actually this is doable in our setup and by our own people. A reduction in fresh stillbirth in this study basically means that providers were able to make decisions to resuscitate, for example, more small, sick-looking babies, among others. So the real question which we should be asking ourselves is, why did providers save these babies in this study or this setup? What was it about the full package of interventions that led these providers to make different decisions, to act as opposed to not acting? This is what we need to concentrate on from this research. And today we are further challenged to translate this work into policy and practice. And we'll be calling upon, of course, this team, as well as other partners, to support us to roll out the quality of care standards for the small and sick baby. Our take here, I think, is that this is a result of careful establishment and standardization of health provider practice in caring for preterm babies through a systematic skills building process and gradually diffusing this knowledge of a set of interlinked and then further selecting and introducing quota improvement methodologies and improved data systems, plus a modified Safe Childbirth Checklist. These few interventions, as you can see, and Dr. Harriet keeps saying that these interventions were not new, these interventions are cheap, and these interventions are doable. So for me, this is our biggest challenge today, to be able to translate this further into our practice. Also, the other issue I want to reflect on is the timing of these results, which I think is very appropriate. In Uganda, for example, the demand for neonatal medical staff or practitioners is growing very fast. As a country, we are in the process of training these practitioners and expanding our NICU teams through a World Bank funded fellowship training program. The study has actually demonstrated that although we are training only 11 students in this program, we can actually multitask our teams on the ground, and they can be capable of actually doing the interventions, working together with our fellowship. So we would like to make sure that these people who have been implementing in this study actually come together with our fellowship students to be able to implement and functionalize our NICUs. The other thing I've seen, which I think is important on the timing, is that this study was conducted in tertiary or higher level healthcare setting, which improved morbidity and mortality. We have been having a debate on where to deliver these preterm babies. We've been discussing where we should put the NICUs and which levels, and that has been a big debate, and some people have challenged the cost-benefit analysis for this work. But this study has further confirmed the importance of delivering these preterm babies in settings where we can actually assure high quality of care as compared to, for example, transferring these infants after birth to the higher levels. So if infants must be delivered in lower level or non-tertiary centers, we need to have transport of the infant by a trained neonatal transport team to reduce the mortality. So I think this information is going to be very important for us as we discuss where should we put these services. Should we regionalize them? Should we decentralize them further? And that's going to be a very good input. This year alone, we've been able to establish 19 newborn intensive care units in the country, across the country. And we're in the middle of equipping them, and we are preparing, as I said, our students to run these units, and we'll need to work with exposed staff from this study. PRONTO training in particular can contribute to a very hastened, a very quick capacity building for our workers. And this is an area we'd like to explore. Another important issue is our focus on the timing around birth, plus, of course, the initial hospitalization phase for some babies. This, however, doesn't put less emphasis on preventing preterm births, but it shows that, and has actually been shown in a study we did with the Saving Mothers, Giving Lives, proof of concept, which was a match donor program, that we can focus around this critical time during and immediately after birth. And this can be a major shift in our programming to end these deaths. Studies have also criticized, and many people actually have a belief that doing quality of care in low-income countries is a myth. And some people think that this will take us a long time. Many people have not invested in quality of care, but importantly, WHO now has realized that quality of care was one of the biggest components which fell in the cracks in the MDGs, and they are pushing countries, they're attracting countries to take on quality of care. So quality of care as a centerpiece of this package is also another very important thing we'd like to take forward, and especially since it was focusing around that critical time, which we are also prioritizing. And we will require strategies and tactics which will be borrowed from this research, especially in terms of maintaining and continuing with the quality improvement for some time, or rather sustaining it as we meet. I wanted to talk about some of the previous work which we have done on quality of care, and I wanted to particularly quote a study, I think it was done in 2016 by Margaret Crook, which concluded that it was a study which was evaluating maternal health programs in Uganda and Zambia. And they actually found very mixed results on quality of care and satisfaction. And that having been done in this country, and now this study which actually has shown, I think shows that there are aspects of this study which are very critical ingredients in making this work. Therefore, this work stands to challenge us, and we'll need to work on translating this evidence into practice. As I said, we need to plan for all the components, preferably with the people at the center, and work on innovations. And as we develop our new sharpened plan, this year we are putting together a new sharpened plan for our MNCH. I think we will need to include some of the lessons to address preterm birth in our strategy. The study also provided a platform for coming up with synergies among government practitioners, academia, policymakers, development partners at some point were also involved. And today we are honored to have some of our partners on this webinar. So we hope that we'll be able to scale up and spread this program to the rest of the country. I know, finally, I know a lot of data has been generated in this study, and it's possible that not all the data has been used for analysis, which was shared today. The data, the metrics, the tools which were developed will provide a future opportunity for us to continue analyzing, and hopefully these findings will be shared and further knowledge generated. And especially the big cohort of 3,000 babies, preterm babies, we have an opportunity of following up these 3,000 preterm babies in this country to look at their environmental care, but also to look at the other consequences. So I hope that this is something which the university and this team can consider. Finally, I think this reflection would be incomplete if I don't talk about preterm and COVID. Preterm in the context of COVID. During this pandemic, and especially during the lockdown, Uganda registered a 20% increase in preterm birth rates, especially the spontaneous one, compared with the similar timing last year. The drastic reduction in the number of antenatal visits during the lockdown has been one of the reasons, but there are also other reasons, including mothers making decisions to seek care. But also the dramatic increase in the number of adolescent pregnancies as a result of locking down the schools, closure of the schools, is a big problem. The study has shown that a fifth of the delivering mothers had a higher likelihood of having poor outcomes if they were adolescents. And as I now understand, the study found adolescents had a higher rate of pre-discharge mortality. And as many adolescents get into our labor room this year and most of next year, I have a belief that we will need to carefully focus and maybe target these babies as part of the bigger picture for preterm births. Core challenges of this pandemic, however, is to meet the dire and presenting needs of all the vulnerable groups, but a focus on the preterm birth, I think, is very eminent. Ladies and gentlemen, I would like now to, at this moment, to make a decision on the type of world which we think we want to put our babies, to have our preterm babies in Uganda. And we have a choice to take this work to the next level, to take these lessons to the next level. And on behalf of government, I would like to take this opportunity to commit ourselves on saving babies born too soon. We've made a commitment and we are rolling out our roadmap. And I would like to end with this for this reflection. Thank you very much once again for having me on this webinar.
Thank you very much for those excellent and wise words to all of us. And definitely, if we were in Parliament, we would be saying you have given us our marching orders for the next 5 years of work. And we are going to see how we can actually make that happen. Now, there's one big burning question that came in, and I think I'll bring this to Jesca and Peter. We have CSOs there are some CSOs who have participated today, and they're asking a question on how can we interest CSOs and NGOs that are in the region take on some of the learnings from this study. So now we are trying to get into the community, and how can the community work with us to learn from this. So maybe I'll start with Peter and then get to Jesca. So over to you, Peter.
Thank you so much. I think I'll just start by thanking Jesca for very excellent reflections. And I'm so happy you captured one of our major concerns, the 3,000 preterms. That, you know, when this study was initially designed, it was for 10 years. But for some reason, we got it for the first phase. And now we miss this opportunity of knowing what is going on. There is a work for a PhD student, Gertrude Namazwizia. She's been following up, and her studies on outcomes of what she calls those vulnerable babies. And we find that neurodevelopmental outcomes are a bit common, especially the risk of these babies becoming malnourished. But in general, Uganda babies, even those who are born normal, are not well stimulated. So she finds in her work some things which lead to some neurodevelopment defects in some aspects. So it's important to learn from these babies. We had some small studies which followed up some of these babies. I actually planning to have another webinar on this, but we need to follow up these babies over time. And good enough, most of them are traceable. So I'd like to invite other people to support this process, including like UNICEF and staff, so that we learn from our own work in Uganda. Now to the CSOs. I think there's various roles for the CSO. One of the things that prematurity, in fact, Dr. Jesca, since we're writing the investment case now, plan, I like, we had a voucher system for deliveries and stuff like that, but we need a voucher system for mothers who deliver preterms, because the cost of care, even in our setting, is very high, and it determines what will come out for these babies. If a mother has to be followed up all the time, then it is a big issue. So CSOs can participate in really supporting mothers when they are being transferred, when they're identified as at risk of developing a prematurity. The care, you remember in our hospitals, they don't provide food and all that kind of support. These are areas, can you imagine a mother staying in a hospital for 2 weeks or a month? Then the issue of peer support, many studies show that when mothers are supported by other people other than health workers, it actually improves outcomes. There was a paper even published yesterday about peer support and stuff like that. Then the issue which Harry talked about, follow-up. Follow-up is an important area, and in most of these hospitals, although we've not actually assessed it, we now have follow-up clinics, but they need to be coordinated, to be supported, and to identify some of those who, not every preterm who survives is going to be to thrive. They need to be supported. So for me, those are some of the things that, and then definitely, Dr. Jesca talked about an important thing. Why did we succeed? And I think that is why in the normal government system, we never succeed as much, because of the management process. This was a systematic process, as she said, a bit standardized, and making sure that the mentorship, the QI and ETC happen. And that kind of process within a strained system is not possible. So CSOs can actually identify some of these hospitals and identify some of the gaps they have and support for the delivery of some of these very important and yet critical interventions. And the other thing which I very much liked from Dr. Jesca's comment was on PRONTO. I think we can learn a lot from PRONTO. In fact, Dr. Jesca, one of the things that potentially during COVID, we can actually develop a PRONTO SIMPAC, and I want to challenge Dilys. Where is the PRONTO SIMPAC? I know you published about it, but can you bring it to Uganda? How can we manage these crises during COVID and ensure there is quality? A simulation system would be able to provide that kind of process. And again, NGOs can support in this. So those are some of the comments I wanted to make, and I'll pass over to Jesca to comment. What else can CSOs do?
Yeah, what else can I add? I think Peter has said most of it, but maybe 3 small things. One, advocacy. We still have an uphill task to advocate for preterm babies. There are many cultural barriers. These babies are not given names. They're not known in some families. They are denied. So we need to raise the advocacy for the need to invest in preterm births. We are beginning to see some improvement, but I think we still need to do much more, including advocating to the men, to the males. We need to push, and CSOs actually can help us here, to push a model, a family-centered model, which can support these babies, especially as they transition from hospital to the communities. Having, I think, a family-centered model, which can help and recognize these babies in a more dignified manner, but also making sure that we are equipping and empowering these families to care for these preterm babies. So I think the grassroots people like the CSOs can play a very big role. And finally, the issue of accountability. Accountability for results. I know there is a data reform going on in many places, and this study has shown us that you need to have data, you need to have metrics. I think we can work with the CSOs much more to make sure that actually people are accountable for the results. They are accountable for the resources they put in, and the results which they measure can actually be shared with people who are very influential in terms of investment for these children. I would like to stop there.
Thank you very much, Peter and Jesca, for those excellent responses. Looking finally, I think this will be the last question of the day. And so there's a question, and this is actually scale up. And I think it's also from the region. How can this intervention reach the lower health center 3 facilities in Kaliro district in Uganda, which also has a lot of babies, and they provide quite a large maternity services, and yet they lack access to training or consultation. So, Peter, something?
You know, thank you so much. For me, the main question is, how do we transfer the learning? And one of my main concerns has always been that Uganda is full of so much successful research and pilot projects. How do we get the learning and translate it to implementation? And so I just want to throw this back to the government, the partners, and the staff, that let's focus on identifying what has worked in our context and package it and support it to scale. And I think the opportunity is now that we are writing a new sharpened plan. And 2, one of the things with a special focus on Kaliro does not even have a hospital. So Dr. Jesca, one of the issues of transfer, we may need to see that, but also transfer in the womb, but also transfer after birth by improving a few places. So we are going to present this result to Frank. I want to challenge you again also to the URC rights projects in the region, because it has some resources, but also I know that Dr. Jesca is leading a team that is supporting mentorship and QI and stuff that are going around the country. And if we could identify some of these places, Kaliro, we've struggled very much because I think there are health center for, we work in one of the health center force, but uptake has been slow. And one of the important things we've seen in the CHOI, that leadership and management are so important. You can't just give people the intervention and they uptake it. So those are areas we need to synergize what we do, plus strengthening the district systems management and support to them. But otherwise, we are going to be presenting to the regional teams in another webinar so that they can learn from this and perhaps be able to uptake.
Okay, thanks, Peter. Jessica, do you have anything to add to translating results into action and scalability?
I think Peter has basically said most of it, but mostly focusing on the opportunities we have. Kaliro is so much close to some of the districts where Peter was doing the research. So I think that shows that we're able to replicate this in Kaliro. And Kaliro, we shall look out for you in the next round.
Yeah, so yes, we shall all strive to learn a couple of these lessons. One of the things that Peter mentioned at the end that he was passionate about was when they transferred this midwife to another health center 3 and she started her. So you really need these champions. I think one of the biggest things we do not have is the issue of championing some of these processes and then also supporting those champions. There's a big push. Kaliro should learn that RBF has come and RBF is an opportunity. Can we see how we can really use the RBF, that's results-based financing. Can we see how we can use the results-based financing platform as well to kind of address some of these issues? Because now with RBF, it is strengthening the bits on leadership, on governance, and even on prioritization at the facility. So these are key areas that I think we now need to kind of address together, and as we shall not leave anybody behind, as they say. I think we are getting to the end. Are there any parting shots from Dilys?
No, thank you. Sorry.
Cool. Okay, thanks.
Thanks, sorry, I can't start my video. I think it was turned off, but I just wanted to say thank you all for this opportunity, and your leadership in the region is really going to take us forward, and we are ready to collaborate and provide the support we can and should be doing. So
sure.
Thank
you. Fregona, any parting shots from our neighbors in the East?
Thank you very much. It was a great honor to work together, and we are hoping that we can continue working together even in the future. Thank you.
Okay, thank you. And on my own behalf and the behalf of the whole panel, I'd like to thank all of you for this active participation. I must say we've been almost full house up to now, and we are looking forward to working very closely with everybody in the region. This webinar has been recorded and we'll be able to share it afterwards, as long as you've sent the email. I mean, we have all your emails, and we'll be able to send it to you all. Thank you very much for participating. I must say we've had about 130 people who have registered, and I think that has been a good record. Thank you very much, and see you in the next webinar. Thank you, Peter and the team.
Thank you.
you.
Bye-bye.
Bye.